Okay, we're live here with Dr. Jacobson from Great Plains Health, Sports and Medicine. This is Jill Stevenson. I'm the patient navigator for the joint replacement program, and we are here with Dr. Jacobson. So I'm going to let you introduce yourself, let us know a little bit about yourself, where you went to school, that type of thing.
I'm Nathan Jacobson. I'm originally from Southern California, but I've lived in the Midwest since college. I went to college at Grinnell, which is a small school in Iowa. Played a couple sports there and kind of got my fix into sports medicine initially there. And then I went to American University of the Caribbean on the island of St. Martin for medical school. I did a year at the Mayo Clinic in Rochester in general surgery. And then I did 5 years of orthopedic training at Wayne State in Detroit. And then I did an extra year of fellowship training in sports medicine at the Trio Orthopedic Institute in the Twin Cities. Ultimately, that is more of the focus of my practice is sports medicine. So that is your ligamentous reconstructions around the knee and the shoulder, rotator cuffs, those kinds of things. But I do pretty much everything in the knee, including knee replacements and partial knee replacements. And same goes for the shoulder with total and reverse shoulder replacements. That's kind of the basics of my training and background. I personally also have a niche with rodeo. That's something that I got into upon coming to Nebraska and North Platte, and that's really helped my practice and has gotten me to know the local flavor a little bit better.
So what's your favorite type of surgery to do?
My favorite surgeries are probably more the sports medicine stuff, cartilage restoration, ligamentous reconstructions.
Okay. So we're going to talk joint replacement. We're going to really talk about total knee replacement and partial knee replacement. So I'm going to have you...
Total knee replacement is really a resurfacing. We leave as much bone behind as we possibly can, but we basically remove the arthritic components at the end of the femur and the top of the tibia. We cap the tibia with a piece of metal or our tibial tray, and we cap the distal femur, resurface it with metal. And then the bearing surface is a plastic component in between the two. Now it's not demonstrated on this model, but you also have your kneecap in the front, and we remove the back of the kneecap or the arthritic part of the kneecap and replace it with a plastic piece as well. So all the articular surfaces or joint surfaces in the knee have been resurfaced with metal and plastic bearings.
What type of metal do they use?
It's a mixture, and it's predominantly is cobalt, chrome, and molybdenum. There are other metal components such as nickel that's in smaller concentrations. If you have a nickel allergy, which does occur in some patients, they do come in titanium components, which does not contain nickel, and therefore we don't have that issue. In exceptionally rare cases, you might have somebody who has a titanium allergy, and then you can actually get implants that are coated with basically a ceramic coating, and therefore it's inert and you don't have the allergy issues.
So what's a partial knee replacement? A
partial knee replacement is where in a more specific patient group where only part of the knee is damaged or arthritic. That might be just the medial compartment, just the lateral compartment, or just the front of the knee, which is the back of the kneecap and the patellofemoral joint. And so we resurface just that part. This is a model of one. So you'd have a normal kneecap in front. The lateral compartment is normal and well maintained, and the lateral compartment was where it was arthritic. So on this model, you can actually put arthritic components on there, showing that it's worn out, and then you resurface those just like with the full knee replacement, with metal on the bones and a plastic spacer or bearing surface in between the two.
So anybody watching Facebook Live, if you have any questions, type them in there and we will ask him as we go along. And I should have mentioned that we are far enough away in here, so he is not wearing his mask, so we are over 6 feet. So we're good there. So can you do bilateral knee replacements?
Yes, I've done bilateral knee replacements and I've done bilateral partial knee replacements. Because you're operating on both legs and makes rehab a little bit more difficult. Yes, overall it's shorter because you have one surgical intervention instead of two separated ones. but it's much harder rehab because both legs have been surgically altered, if you will. So you generally have to be a little bit younger, a little less heavy set, more of an athletic type build. And one of the things I like to get my patients to do who are considering bilateral totals on or bilateral partials is whether or not they can do some dips. And now I'm not talking about on a parallel bars, but just on a chair, lifting your body weight up on your hands and being able to lower your weight up and down 10 times using only your upper body. Because ultimately, once you've operated on both legs, how are you going to get up from a chair? Normally, if you had one side operated on, you can slide the good leg back a little bit, put more load on it, and help rise up using your arms as needed. Well, if you have both done, you might have range of motion issues or just the pain from the post-operative state in general. And so you're going to rely much more heavily on your upper body and your shoulders to get up out of chairs and out of bed, those kinds of things. So we want to make sure that we're setting you up for success and not setting you up for failure, that you're a little bit more physically fit, a little bit more strong up top to handle that extra burden.
Okay. And I've heard about PSI. Can you tell us a little bit about what PSI means?
PSI is patient-specific instrumentation, and that's done where we get an MRI or a CT scan, preferably an MRI of the knee before surgery. But if you have metal components, like you had an ACL and there's a metal screw in there, we can do the same thing off of CT scan. But they take sections from your hip, your knee, and your ankle so that we can get the full alignment of the leg digitally on the MRI, and it allows me to do the surgery on the MRI, off of the MRI on the computer, instead of doing it just on you. It gives us an extra double check. And so these are not specific, obviously, but if we have the patient's knee, the femoral guide locks onto their osteophytes and nobody else's, and these pins that we put in guide the entire procedure and all the cuts from there. The same thing happens with the tibia. It locks onto the front of the tibia and the posterior medial aspect of the tibia. These two pins and these two pins guide the entire procedure from the tibial standpoint. So it's just one extra thing that you can do to double check your alignment preoperatively and try to give the person the best knee that they possibly can. We normally quote people that knee replacements or total joints last somewhere between 20 and 30 years, but we really want to push that 30-year number in a younger, more active patient. And so I use the PSI actually quite a lot in my patients.
So we have a couple questions coming up on here. Go back to the beginning here. So I have a question that says, I got both knees fully replaced 2 years ago. I still have lots of pain and swelling. Is this normal? Is there anything I can do to help?
There's a lot of reasons why you could still have swelling. One of the main things, just from the trauma of the surgery, your knees tend to be a little bit more puffy. They're not as svelte as they possibly were before. So some puffiness and swelling just at baseline is normal. But if you're having recurrent effusions, which is increased swelling in the joint itself, that's more worrisome. That can be due to an infection. Low likelihood, but it's one of the first things we think about and we have to rule out. So draining some fluid out and testing it for infection is one of the first things we do. Also, you can do some blood work for that. We also would get imaging to make sure that there's no component loosening. So unfortunately, once in a while, the components do become loose and the interface between them and the bone breaks down, and that will cause swelling and pain. Unfortunately, there are some other soft tissue balancing issues that can also sometimes be an issue. Resulting in some instability, those kinds of things. Different types of knee replacements. The one I tend to use is a posterior stabilized knee. So it has this metal post in it, and it has a post in the back on the femur that acts as a cam to help guide the motion. That type of knee replacement does not require a PCL. And every once in a while, when you use the other type called a cruciate retaining, that does rely on the PCL can tear or fail over time, and that can lead to instability type symptoms and pain and swelling. And basically you have to revise that.
Okay, so the same person who asked that question, Michelle, said, I'm also getting sores around my lower legs. Could this be from infection?
That is possible, and it sounds like, unfortunately, you need to come in and be seen by somebody because this could be the precursor of something bad going on. You can also get lower leg skin breakdown, ulcers, those kinds of things from peripheral vascular disease and blood flow issues, and that could also be a contributor to issues with the knee joint itself.
Okay. And we have a message from Julie. She said, I had bilateral partial knee replacements 3 years ago with Dr. Jacobson, and I'm doing very well.
Well, thank you. Glad to hear it.
Patient on here says, I may still be interested in patch shoulder pain.
Patch shoulder?
Yeah.
I'm assuming that you're referring to something called patch augmentation. And I use that sometimes with rotator cuff tears, where the tissue is either not the greatest quality or it's been a revision situation, those kinds of things. And you can take a piece of Achilles tendon from a cow. I like to refer to it as a magical set of cows or magical herd of cows from New Zealand because it is from New Zealand. But you have linear collagen, and you can lay that over top of your rotator cuff repair or off of a partial tear of the tendon, and your body incorporates that, thickening the tendon. The thickness of the tendon is directly proportional to the strength, so that can be used as an augment with partial tears or with full thickness tears and rotator cuff repairs.
What age do you recommend for a partial replacement, provided one is in moderate to good physical condition? That's from Tracy.
Age is really more of a, is really patient specific. You have patients who are 70-year-olds going on 50, and you have 50-year-olds going on 85. And so it's really what is the individual patient's biological age and their activity level that really dictates it. If the more active they are, the better the partial knee option is, as long as the other two components or other two compartments of the knee are well maintained. So going back to this one, for me to do this partial knee replacement, this side would be bone on bone or near it and in really bad shape, whereas the patellofemoral joint and the lateral compartment are pretty much pristine. Other things that you worry about with partial knee replacements is, okay, this lateral side doesn't have any arthritis, but the patient had a meniscus tear and that meniscus was removed. Well, that side of the knee is set up for earlier wear and tear, and you might want to consider that in whether or not you're going to do a partial. The more factors like that come up, then you start leaning more towards a total knee replacement. Bone quality also is one. Somebody who has osteoporosis, when you do this vertical cut, this small vertical cut right here, that can be a stress riser to crack through if the patient has poor bone quality. So somebody who is osteoporotic or has osteoporosis, that might be somebody that we probably should shy away from this from as well.
Can you tell us why some patients get cemented implants and some are non-cemented?
So cemented implants are kind of the gold standard. That's been around for years and years and years. So it's what we use most commonly, and really it's like a grout. So we cover the surface of the metal implant and the bone, and it wedge it together, and it interdigitates like grout with tile and holds it in place. And just like grout and tile, the metal is really durable and doesn't tend to break down. The plastic pieces we have now are very good, and those don't tend to break down or wear like they did 20 years ago. So that interface is one of the areas that is a potential weak spot and could lead to loosening as that interface breaks down over time. A press fit knee, the back side of the metal has a different structure on it or a different coating on it, trying to facilitate bony ingrowth so your body actually grows into the implant instead of you basically gluing it or cementing it into place. So we tend to we're using more and more press fit components because of this potential for the interface to be healable or get stronger over time. And there's literature that shows that actually might give a better outcome in heavier set patients, but you need to have good bone quality. Again, the osteoporosis thing is an issue. That's going to be a better patient for cementing. And medical comorbidities come into play big time with it. If you have any concerns about bone growth and bone healing into the implant, you probably should go with this cemented, which is the tried and true. We don't have 30-year data on press fit knees. We do have 30-year data and over that on cemented knees.
So do you recommend prehab or physical therapy before surgery?
Yes, and in my patients that are online, you might have even got annoyed with it. But ultimately, prehab is very, very important. There's a ton of research out there, a ton of literature that shows that even just 2 weeks of organized physical therapy, those patients do better than the patients who didn't have preoperative physical therapy. So I think it's an absolute must. Only in rare situations do I not push for that. And it's just as simple as you learning the exercises when there's not a whole lot else going on. Post-operatively, there's a lot of different moving parts, from your pain medications to the rehab to the way just your life is affected and is changed during that recovery phase. And if you've already learned the basics of your rehab and the exercises, you've learned that for the last 2 weeks, 3 months, whatever, you hit the ground running much more quickly. From the rehab standpoint. Plus, any improved strength or functionality you get from the rehab up front is just going to help you rehab as well post-operatively.
What is the recovery time after knee replacement? Like, how long before I can kneel? How long can I do, how long do I have to wait to do weightlifting, those type of things?
Okay. So there's different milestones that we look at for after a total joint. The first one is weight bearing. 30, 40 years ago, you might have had restrictions with that. Now we want to get you up and get you walking the day of surgery. Post-op day 0, you will get up and you will walk. Another milestone we look at, staples or sutures tend to be removed at the 2-week mark. We really want to get your range of motion at full extension immediately. You will have full extension by the time when you leave the operating room, and then it's up to the patient really to keep that. We want to get 0 to 90 within the first 6 weeks or so. Driving, I tend to recommend to my patients that they don't drive for at least 6 weeks. Ultimately, there's research that shows that your reaction time is delayed for at least 6 weeks. And when they do start driving again, I recommend that it's you practice in an abandoned parking lot or an open field, those kinds of things, so you can see how your leg's going to work for you, because you will be slower. Also, you should be off of all of your narcotic pain medications when you start driving. Otherwise, you are by definition driving under the influence. People going back to jobs where they're sitting down doing desk work, computer work. I've had people go back to those jobs as quickly as 2 weeks. As long as they were able to have the accommodation of, I could have my ice machine on my knee underneath my desk, I could get up and walk when I needed to, those kinds of things. People who have to be on their feet for long shifts, those kinds of things, they tend to be closer to the 3-month mark. As from a kneeling on the knee standpoint, that's really a patient-specific thing. Biomechanically, you can kneel on your knee replacement. It's not going to hurt the knee or damage the knee. I did a bunch of my training in Detroit, and they have one of the largest Arabic populations in the country and a large Muslim population. So they got down and prayed on a regular basis on their hands and knees, and we studied them as a group compared to our non-Arabic patients. And ultimately, the failure rate was the same. So it does not lead to loosening, does not lead to complications getting down and kneeling. But a lot of patients will have pain with it. A lot of patients will report just that it feels awkward because they can feel the plastic, especially the kneecap, kind of sliding funny in the front of the knee. It just doesn't feel right. That's my mom. My mom has some mild discomfort when she kneels on her bilateral total knees, but it's and a little bit of pain. So I got her a set of knee pads for guys that lay tile. Has about an inch gel pad on the back of it, and in kneeling on those, she doesn't have any discomfort, and she can get down and work on a hardwood floor again. Also, if she's gardening, if she turns the soil and kind of softens it by turning it, she can kneel directly onto them. If it's hard soil, then she uses her knee pads.
Is there any weight restrictions to having a knee replacement?
There's as we get heavier, or I'll use the word fluffy, their risks go up and the complication rate goes up. Initially, that you see the first bump at a BMI of about 35, and then you see a much bigger bump when the BMI hits 40. Ultimately, these are metal and plastic, and just you can buy a Pinto or you can buy a Ferrari, but metal or plastic, it does wear out over time, and it can only handle so much stress. So when you start getting over that BMI of 40, we get really kind of cautious about knee replacements. There is no hard and fast number, but 40 is where we really start to get concerned.
How many days will I be staying in the hospital with surgery?
Good question. That has changed dramatically. When knee replacements are first done, you might be in the hospital for a couple weeks. Now the vast majority of our patients are going home the same day of surgery, and we have a few patients that stay overnight and go home the next day. And that's changed dramatically over the last year to 2 years, especially with COVID trying to get people out of the hospital and out of that potential exposure risk. The rules still exist that if you're looking at going to a nursing home or rehab facility, that you have to be in the hospital for 3 days, but qualifying for that hospital stay and then qualifying for the rehab stay, those restrictions have gotten much, much more rigid, and it's a lot harder to qualify for those things. And you really have to have a lot of medical comorbidities or really be laid up to be able to qualify for that. So most of our patients go home the day of surgery or the next day.
Some physicians do not use ice machines. Are there any additional benefits over ice bags?
Other than the lack of spilling water all over the place, there's probably not a huge difference between the two. I really like the ice machines. The ice bags, you have to have, if you have a significant other that's really helping you out and changes those bags regularly, you're going to do great. But the ice machines hold more cold water volume, and they last longer. You have to change those things less. So I really do like them. I have one myself for when I have aches and pains at home. But ice bags are really probably just as efficient.
We do have a lot of patients that do frozen water bottles in the ice machines.
Yep.
And so then you're just having to switch out water bottles and you're not using as much ice. So
that's a good idea.
How about the anesthesia, nerve blocks with knee replacements?
Most of our patients have a block and a spinal, but that does not mean that you're awake during the case. Everybody sleeps through the case. They give you medications. You don't remember things. But when we look at anesthesia, there's different levels of it. The way it was described to me in my training is you think of a ladder, and as you go down rungs of the ladder, you're going deeper and deeper under until eventually you're having machines breathe for you. That's truly being under anesthesia. So what we do, we try to minimize the amount of anesthesia that you need overall, so that it's less stress on your heart and lungs, and you're basically breathing on your own during the case, but you're sleeping. So all of my patients get blocks, and I like an adductor canal block. Femoral blocks used to be much more popular. Most of orthopedics has gone now to an adductor. It's an injection in the lower anterior aspect of the lower thigh. It used to be higher up near the groin for a femoral, but by moving it down, we still get the pain nerves that go to the knee, but we spare a lot of the nerves that go to the quad, so your quad function stays where it's supposed to be, and you can get up and walk easier the day of surgery while that block is still in effect. And that really helps quite a bit with pain. Intraoperatively, we then use an injection that's a cocktail of different medications, and inject that into the joint capsule, predominantly in the posterior joint capsule, to help hit that area. And then the spinal anesthetic is an injection in the back that kind of numbs you from the waist down, and they can titrate that so it lasts a couple hours basically during the surgery and wears off pretty quick afterwards, so again that you can get up and move right away.
Okay, so I have some COVID questions
Okay.
now. So COVID vaccine, do I need to have any time in between COVID vaccine and surgery? And what happens if I get COVID? Can I still have my surgery?
So if you've had COVID and recovered, you can have surgery. We really would want you to be over the symptoms of the COVID before undergoing surgery. There are other respiratory illnesses that have lingering effects for months and months and months. We don't know the lingering effects truly at this point of COVID. There are some people that are over it very quickly, and they could probably go to surgery pretty quickly afterwards. But those people who have the chronic long-term pulmonary symptoms from COVID, that patient should probably have their surgery delayed until we've had them get over those symptoms, or we've gotten a new baseline for them. As for the COVID vaccine, I'll get on my little soapbox. I'm a medical professional. I recommend the COVID vaccine. That being said, ultimately, we do want to make sure that there's a window around the vaccine and your surgery. And the reason for that is that I'll talk about my vaccine. My first injection, I got in the arm, had a little bit of soreness at the injection site. When I had the second injection done, I had diffuse body aches and some chills. Some of the people I work with even ran some low-grade temperature for a couple days. And ultimately, we want you to be far enough out from your vaccine that those symptoms have gone away. And we wouldn't want you to have your vaccine done quickly after surgery, again, because we want that window so that things aren't being confused for one another. If somebody were to develop an infection, but they just had the COVID vaccine the day before, it really throws a major monkey wrench into the decision making as to whether or not we're going to treat this infection and take the patient back emergently to the OR to wash it out and clean it and try to save the knee, versus saying, this is probably from your vaccine and we need to give it a few days. Well, in those kinds of situations, those few days could be a big difference as to whether or not you keep or you lose your knee replacement and have to go through the multiple surgeries and washouts and all that. So right now we try to keep have patients get their vaccine at least a week before a surgery, so they have a week to get over any symptoms from the injection or from the vaccine, and then we want them to wait at least 2 weeks after their surgery before they get vaccinated. So again, that they're over that first hump, and you're outside that initial window where you have a higher risk of urinary tract infections, respiratory infections, just from being under anesthesia.
What improvements have you seen in the hardware implants over the last 5 years?
Over the last 5 years, the main, it's probably going to be longer than 5 years, but the main improvements is there's been tweaks to the design so that it's a little bit more form-fitting to the patient and a little bit more anatomically accurate. The plastic piece has made huge leaps and bounds forward. And now we also are in the system I use. They also will impregnate vitamin E into the plastic or into the poly piece, and that's supposed to help prevent free radicals and therefore help prevent some of the potential loosening issues that can occur. The press fit technology has come a long ways very, very quickly, and the literature on that, the research on that is getting better. And I think that in the future, that might be where we're at full time with everybody, but we need to give it a little bit more time for that to work itself out. You can't have 30-year data in less than 30 years. Unfortunately, that's just we got to earn our stripes to do those things.
We have a comment that says best doctor ever.
Oh, thank you.
So we only have a couple minutes here. What are the complications after a knee replacement that you might see?
So complications after surgery, pain control issues, swelling, those are going to be our two most common ones, and everybody to some extent has that. You just got to work with it. The next thing we look at is there's a 3-day window where we look at wind and water. Wind referring to respiratory infections, pneumonias, those kinds of things, and atelectasis. Atelectasis is where your lungs collapse down. You can get a fever from that. So we always have patients do breathing treatments to try to help keep their lungs puffed out. Water is referring to urinary tract infections. We don't routinely use Foley catheters with joint replacements, and that has been one of the biggest changes over the past probably 30 years now, to decrease the risk of urinary tract infections with joint replacements. Wound issues is the next thing that we look at, and those generally take a little bit longer to show up. We have all of our patients come back at 2 weeks for a wound check and suture removal or staple removal, and then our physical therapists are also an invaluable tool to look at that incision routinely when they're seeing the patient each week or a couple times a week. And if they have any questions about the wounds, they see a lot of them. If there's any concern, they get a hold of us and we get you in immediately that day.
Okay, so it's like 12:30, but we have one question left on here, and then we'll let you go. And then if anybody has questions later, you can still post them, and then we can answer them we can type in your answers later. But prior to the doctor's appointment, what do you need to bring with you to the appointment if we've already had x-rays, or do we take x-rays again?
If your x-rays have been done within the last few months, I would say try to bring them on a disc so we could upload them into our system. That being said, not all x-rays are the same. And so there's a specific x-ray that I like to get. It's called a Rosenberg view, or a 45-degree PA weight-bearing view. And all it does is when you take a normal AP x-ray or anterior posterior x-ray, you stand in your knee joints like this. And you can have a space that looks like that knee is pretty healthy. But if you flex them 30 to 45 degrees, all of a sudden that space might disappear and they're bone on bone. And that's the most sensitive x-ray for looking for knee arthritis. And so a lot of times if I have a patient that comes in, their x-rays like this, and it looks good, but you see some hint of some osteophytes on the side, or their symptoms just warrant a deeper look, you get that 45 Rosenberg, and all of a sudden they're bone on bone, and that changes the treatment pretty quickly. Any kind of documentation or bring in any information that you've done physical therapy or you've done steroid injections. If you've had a steroid injection or a viscosupplementation injection, if you could bring the date in or the ballpark of the date of that injection, that can be beneficial as well.
Okay, so we're going to let you get back to seeing patients or going to surgery. Thank you guys for joining in. Thank you, Dr. Jacobson, for your answers. But anybody has any questions, just type them on there and we will answer them later. Thank you.